Myocardial ischemia, injury, and infarction. 20. Myocardial ischemia, injury, and infarction. Fast and easy ECGs. Secondly, a self-paced learning program. Myocardial oxygen supply. Because heart's oxygen and nutrient demand is extremely high, it requires its own continuous blood supply. Myocardial oxygen supply. Coronary arteries deliver blood to myocardial cells. Coronary veins return the oxygenated blood to RA via coronary sinus. Coronary blood flow can be increased through vasodilation to meet increased myocardial oxygen demands. PR segment. Flat line that extends from P wave to Q wave, or a wave in absence of a Q wave. Q wave, first part of QRS complex. First downward deflection from baseline. Instructional point. The Q wave is not always present. Saint segment. Flat line that follows the QRS complex and connects it to T wave. Instructional point. The saint segment can be compared to the PR segment to evaluate saint segment depression or elevation. T wave. Slightly asymmetrical and oriented in same direction as preceding QRS complex. Ischemia, injury, and infarction. Occurs with interruption of coronary artery blood flow. Often a progressive process. Instructional point. Progressive process which includes 1. Arteries narrow from atherosclerosis and form plaque. 2. Narrowing causes a decrease in perfusion and ischemia to cells. 3. Causes angina or ischemia to the muscle cells. Myocardial ischemia. Results from decreased oxygen and nutrient delivery to myocardium. Can be reversed if supply of oxygen and nutrients is restored. Instructional points. Myocardial ischemia typically occurs when the heart has a greater need for oxygen than the narrowed coronary arteries can deliver, or there is a loss of blood supply to the myocardium. Ischemia can be transient, such as in angina, or it can be related to myocardial infarction. Myocardial ischemia causes: atherosclerosis, vasospasm, thrombosis and embolism, decreased ventricular filling time, tachycardia, decreased filling pressure in coronary arteries, severe hypotension or aortic valve disease. Myocardial injury results if ischemia progresses unresolved or untreated. Myocardial infarction. Death of myocardial cells. Instructional point. The area of the heart which is normally supplied by the blocked artery goes through a characteristic sequence of events described as zones of ischemia, injury and infarction. Each zone is associated with characteristic ECG changes. ECG indicators. Instructional point. Although the ECG usually progresses through these three stages during an acute myocardial infarction, any one of these changes may be present without any of the others. As an example, it is not unusual to see saint segment depression without T-wave inversion. Myocardial ischemia. Characteristic signs. T-wave inversion occurs because ischemic tissue does not repolarize normally. Instructional point. P-wave inversion also be present during a myocardial infarction as the tissue around the infarct becomes ischemic. T-wave inversion. Instructional point. Because the chest leads are closest to the ventricles, they are the best for checking for T-wave inversion, as it will be most pronounced in these leads. Used in this context, the term symmetrical means that both right and left sides are mirror images. Peak T-waves may be seen in early stages of acute myocardial infarction. T-waves invert within a short time, 2 hours. Saint segment depression may or may not include T-wave inversion. Instructional point. Remind the student that saint segment depression or elevation can be evaluated by comparing the saint segment to the PR segment. Flat saint segment depression results from subendocardial infarction. Sane segment elevation. Earliest reliable sign that myocardial infarction has occurred. Instructional point. Myocardial injury produces sane segment elevation in the leads facing the affected area as depolarization of the injured myocardium is incomplete, with the tissue remaining electrically more positive than the uninjured areas surrounding it. Sane segment elevation may also be seen in ventricular hypertrophy, conduction abnormalities, pulmonary embolism, spontaneous pneumothorax, intracranial hemorrhage, hyperkalemia, pericarditis. Sane segment elevation, pericarditis. Instructional points. With pericarditis, uninflammation of the heart, the sane segment elevation is usually flat or concave, the middle sags downward, and seen in all leads except AV. This resolves with time. It also seems to elevate the entire T wave off the baseline, with baseline gradually slanting back downward all the way to the next QRS complex. The P wave is often a part of this downward slanting of the baseline. A ventricular aneurysm, which is a weakening and bulging of the ventricular wall, should be suspected if sane segment elevation following a myocardial infarction persists. Pathologic Q waves indicate presence of irreversible myocardial damage or myocardial infarction. Instructional point. Myocardial infarction can occur without the development of Q waves. Pathologic Q waves develop because infarcted areas of heart become electrically silent, fail to depolarize, as they are functionally dead. Progression of myocardial infarction. During MI, the ECG often evolves through 3 stages: ischemia, injury, infarction. Criteria for diagnosing MI. Based on the presence of at least 2 of the following 3 criteria: clinical history of ischemic type chest discomfort/pain, rise and fall in serum cardiac markers, changes on serially obtained ECG tracings, ECG changes in MI. 12-lead ECG should be immediately performed on anyone even remotely suspected of experiencing MI. Because early ECGs do not always reveal MI, it is important to obtain serial 12-lead ECGs throughout patient assessment and treatment. Particularly true if first ECG is obtained during a pain-free episode. Identification of MI. ECG changes need to be present in 2 or more contiguous leads. Identification of MI. Reciprocal changes seen on 12-lead ECG may assist with distinguishing between MI and conditions that mimic it. Identification of MI. Closely scrutinizing the contour of the sane segment may also be helpful. With MI, the sane segment tends to be straight or upwardly convex, non-concave. Additional indicators of MI. A new, or presumably, new bundle branch block can be another indicator of MI. However, the patient's old ECGs must be used to confirm this. Left bundle branch block, as well as pacing, can interfere with identifying acute MI by making it difficult to accurately interpret the sane segment. Identifying myocardial infarction location. 12-lead ECG can help identify which coronary artery or branch is occluded, as well as the area of the heart which is ischemic, injured, and/or infarcted. Leads 2, 3, and AV provide a view of the tissue supplied by the right coronary artery, whereas leads I, AV, V1, V2, V3, V4, V5, and V6 view the tissue supplied by the left coronary artery. Septal ischemia, injury, infarction. Identified though ECG changes seen in leads V1 and V2, anterior ischemia, injury, infarction. Involves anterior surface of left ventricle. Identified though ECG changes seen in leads V3 and V4. Instructor note: leads V5 and V6, while located more laterally, may also help identify anterior infarction. Lateral ischemia, injury, infarction. Involves left lateral ventricular wall. Identified though ECG changes in seen in leads I, AV, V5, V6. Lateral ischemia, injury, infarction. The positive electrode for leads I and AV should be located distally on the left arm, and because of which, leads I and AV are sometimes referred to as the high lateral leads. Because the positive electrodes for leads V5 and V6 are on the patient's chest, they are sometimes referred to as the low lateral leads. Inferior ischemia, injury, infarction. Involves inferior surface of the heart, diaphragmatic surface of heart. Identified though ECG changes in seen in leads 2, 3, AV. Posterior ischemia, injury, infarction. Involve posterior surface of the heart. Look for reciprocal changes in leads V1 and V2. Posterior ischemia, injury, infarction. Can be identified through leads V7, V8 and V9. Right ventricular ischemia, injury, infarction. Can be identified using leads V4R, V5R, V6R. Practice makes perfect. Determine the likely location of ischemia, injury or infarction. Answer: anteroseptal infarct, H undetermined, pathologic Q waves in V1, V2 and V3, SAINT and T wave abnormality in V1, V2 and V3, SAINT segment depression in V4, and marked SAINT segment abnormality, possible inferior subendocardial injury, depressed SAINT segment in lead 2, 3 and AV. I. Practice makes perfect. Determine the likely location of the ischemia, injury or infarction. Answer: inferior valmi, pathologic Q waves in 2, 3 and AV, SAINT segment elevation in 2, 3 and AV. I. Practice makes perfect. Determine the likely location of the ischemia, injury or infarction. Answer: anterior wall injury, SAINT segment elevation in V2 and V3. I. Practice makes perfect. Determine the likely location of the ischemia, injury or infarction. Answer: inferior lateral wall ischemia, SAINT segment depression and T wave abnormality in leads 2, 3 AV, V5 and V6. I. Practice makes perfect. Determine the likely location of the ischemia, injury or infarction. Answer: consider lateral wall ischemia, SAINT segment depression and T wave abnormality in leads V5 and V6. I. Summary. Coronary arteries deliver blood to the myocardial cells while the coronary veins return the oxygenated blood to the right atrium via the coronary sinus. By increasing coronary blood flow, mostly through vasodilation, the coronary arteries satisfy increased myocardial oxygen demands. Summary. The SAINT segment can be compared to the PR segment to evaluate SAINT segment depression or elevation. The Q wave is the first downward deflection from the baseline. It is not always present. The SAINT segment is the flat line that follows the QRS complex and connects it to the T wave. The T wave is slightly asymmetrical and oriented in the same direction as the preceding QRS complex. Summary. Myocardial ischemia, injury and death can occur with interruption of coronary artery blood flow. Myocardial ischemia may cause the appearance of T waves and SAINT segments to change. A flat depression of the SAINT segment results from subendocardial infarction. Summary: SAINT segment elevation occurs with myocardial injury. It is the earliest reliable sign that myocardial infarction has occurred and tells us the myocardial infarction is acute. Pathologic Q waves indicate the presence of irreversible myocardial damage or myocardial infarction. Leads V3 and V4 provide the best view for identifying anterior myocardial infarction. Summary. Lateral infarction is identified by ECG changes such as SAINT segment elevation, T wave inversion, and the development of pathologic Q waves in leads I, AV, V5 and V6. Inferior infarction is determined by ECG changes such as SAINT segment elevation, T-wave inversion, and the development of pathologic Q waves in leads 2, 3, and AV.